So thank you, Anaga,
Right,
for doing the Rexes beforehand only.
Yes,
Anaga?
ma'am, I know we are running short of
So
time.
we
Should
have Dr.
start?
Anaga Hirur with
दो
us,
dialer.
who is from Anil Eye Hospital, Dombivli.
आंटी लाइट में देखिए.
We have 58 years old female and we are going to operate the left eye. The vision in the left eye is 6-9 parts, improving to 6-6 parts, and the cataract is soft NS1 plus PSC. Fundus is normal and we are going to implant geometric
आंटी, आपको
trifocal
थोड़ा लाइट में
lens.
देखना है.
Over to Dr.
Hello
Over to
everyone.
Dr. Anaga Hirur, ma'am.
लाइट में देखिए. Our patient is requiring to.
We have the microscope view, please. Microscope view.
आंटी लाइट में देखिए. हाँ, देखते रहना है वैसे, हिलना नहीं. So we have already done the side port and the main incision 2.2 millimeter incision. आंटी आपको लाइट में देखना है चौथा.
So is it a very hard cataract or we don't have
No,
coaxial
it's a
view?
moderate one. I've done the hydro.
So we don't have the
That's why
retro
You
illumination.
don't, yeah. Auntie light में देखिए, she's not looking down at all. आंटी थोड़ा पानी आएगा, प्रेशर आएगा, देखते रहिए. Scalp mode. Yeah.
Yeah, she did.
30 power, scalp mode. Audio भी रखना please. So I'm just removing the cortex from above. Chop पे लेना. Saline please. Not a very 1 minute. स्कल्प पे लेना, स्कल्प पे, या सिंस्की हुक देना मेरे को लेफ्ट हैंड में. ये देना सिंस्की हुक. सलाइन प्लीज. So rotating the nucleus to 180 degrees. The stop and chop mode. Yeah. Separating the two fragments. Quadrant mode, please. It's focusing. I hope it's centered and well focused.
Yes, it is.
Are you using, Anjana?
So
Signature Pro.
So using the Signature Pro.
Using the
Which machine are you using? Signature Pro.
36 aspiration, 400 vacuum, 35 power, 2.2 millimeter incision, 80 bottle height.
Signature Pro, yeah.
लाइट में देखना है आंटी, अच्छा कर रहे हो. I hope it's centered and focused well.
Yes, we can see well, Anaga. You're doing
Last
well.
piece now.
Right.
Reduce the this thing, epinucleus mode, please. Yeah. So at the last piece, I usually go on to the epinucleus mode. Yes, so the final nucleus part is done. Can I have some visco? And then we go on to the IA mode. IA, I'm using the bimanual IA now. Yeah. Yes, please. अच्छा देख रहे हो आंटी. So I'll be using the geometric trifocal. So it's an excellent trifocal. Central 3.2 millimeters is the central diffractive zone and outer refractive for distance. It has the geometric and geometric plus. So I'll be using the geometric one, which has 50 for distance, 20 and 30 for intermediate. And the geometric plus has almost 40 for near. So you can have a very good paired approach where you use geometric in one eye and the geometric plus in the other eye. IA1, please. Yeah.
But if you have cataract only in one eye, what do you implant in the first eye for distance?
I use the geometric.
Yeah, the geometric and then the geometric plus.
Yeah. Because they have very good vision for near, even in the plane geometric also.
So one gives a a better addition and one gives a little less addition. That's the thing.
No, no, the addition power is the same.
Yeah.
The distribution of light for near is almost double. So if you see plain geometric, that has 20 for near. I'm changing my hands. And geometric plus, just open this please. And for geometric plus, it's almost 40. So you have geometric in one eye and geometric plus in the other eye. Then the patient has very good vision for near, as well as intermediate and distance also. So it gives a very good eye. 2 please, polish me, yeah. So whenever there's very flimsy cortex left behind, so you can first loosen it up with the, yeah. We're done, yeah. Give me visco please and the lens. Auntie, अच्छा कर रहे हो, सामने देखते रहिए. So this goes in very nicely through a 2.2 also. It's an excellent multi-cert. I'll just show you. Show me please. Yeah, visco please. So you can see here, this is the number 1 which is written. You put in visco first till the tip. Then number 2, you have to open this case. Number 3, you have a slider which you slide. And then just check whether it's moving forward. Yes. Just hold this please. Yeah. Now we'll go on to the eye again. I'll use the SCI mode so you can see well. 1 minute, increasing the magnification. Give me a Sinsky hook in the other eye. Other hand, yeah. So we can see the rexis now, and 1 minute just. Yeah. It's focused hopefully.
It's not well focused
Not
and
focused,
centered.
yeah, I know. I can't see it. 1 minute, I'll just raise the
Yeah,
micro.
it's better now.
1 minute. Yeah, it's better now. No? Yeah. So it has a tip, no? There is a very long nozzle. So there's a slider. If you use the long nozzle, you can go directly into the bag. Auntie ji, side, दाढ़ी ऊपर कीजिए. हाँ, बस.
So Dr. Anaga, the multi-cert allows you for both a push type delivery and a
Yes,
screw type delivery. So which is your preference?
The push type.
Yeah.
Yeah. So
I
I'm
think
just
most surgeons will prefer a single-handed because they are already using the second hand to
Already, yeah.
stabilize. Yeah.
So you have a choice here, a screw type and a push type.
Sinsky
And
hook
the
देना.
mechanism is excellent in the Hoya lenses
आइए,
because
हाँ.
it never flips.
Light में देखते रहिए. So at this point, you ask the patient to look into the light and see whether the central lights are focused or not. So it gives a very good centration. When you're doing it under topical, you know that you're centered also well. So the geometric has the Vivinex platform, which is the best part. So there's totally non-glistening. IA1 please. And the patient has excellent vision, very low PCO rate, one of the lowest in what we are using, and excellent preloaded technique. I think amongst all the trifocals that are available, the biggest advantage is it's totally preloaded with the multi-cert, no touch technique. And no matter what the IOL power is, whether it's 10 or 20 or 30, the ease with which you can implant it is equal, very, very smooth and consistent. So I think that is one of the most important features of this. And I've been using not only Vivinex, but the Vivinex Toric as well as the geometric lenses very, very wonderfully. And I've been very happy with their results too. So that's the end of the case. Any questions from your side?
No, excellent surgery and an
is the
excellent
next-
lens, I think, because both the lenses are also have low PCO rate, and most importantly, the injector system in these lenses is extremely good in the Hoya lenses.
Yes, yes.
Meanwhile, is the second OR ready? Can we switch over? Excellent surgery, Anaga.
Thank you so much,
With beautiful
everyone.
surgery.
Thank you, Namrata ma'am, and Dr. Gaurav for the excellent OT.
Can we switch to the other OR?
Sir, thank you. Yes, yes. Thank you so much. Yeah, thank you.
Thank
हो
you.
गया आंटी जी, अच्छा हो गया.
I think the AV team needs to be
AV
ready
team,
for
Hello.
the
can-
surgeons.
Yes.
Pino can?
Yes, we can hear.
Yeah, pakado. Hello.
We can hear you.
Yeah, okay. Good afternoon, Dr. Maipal here. I have
Good
just
afternoon,
done
sir. We are waiting for your
Afternoon.
case.
Yeah. No, Visco dena. I have just done a catalyst on this. Just to save time, I haven't shown you the catalyst. But anyway, just put a little bit of phenocaine, just injecting some viscoelastic. I don't normally make the incisions. Main entry, yeah, forceps. Pakdo. So typically I do a 4-quadrant and 1000 micron. If the cataract is hard, I'll just prefer to do 6 to 8 quadrant. So anyway, this is, he doesn't have much of astigmatism, I think 0.3 or something. Visco. ये पकड़ ले यार, मेरा हाथ खाली कर दिया कर. So you can see that it was a free floating capsulotomy. Can you see that? This is already detached needle. ये पकड़ो यार, मेरा हाथ खाली कर दिया करो जब भी मैं. You can see that?
Yeah.
That's hydro. I do a very teeny weeny kind of hydro just to see that everything is all right and to just lift it slightly. You can see that's pretty all right. Now, visco de do or feco de do. Chopper. Forceps. ये पकड़ ले यार, मेरा हाथ खाली कर दिया कर गुरु. एक I normally use a sharp chopper with you can see the rexis has gone in. Chopper चाहिए बेटे. You can see that the rexis has been aspirated. You can see this chopper. This is sharp from below, as also a cutting edge. So that's the pre-chopped actually. Is cornea wet karo. Is it focused well enough?
Yes, sir. We could do
Anything
with
you
some
want me-
viscoelastic on the cornea. Yeah, now we.
डाल
it's
दो
clear.
भैया visco. So you can see visco डाल दे. डाल. डाल डाल डाल. So we have the sections which are there. Again, you can see pre-chopped, already pre-cut.
So you do a
Quadrant पे कर दे
complete
बेटे.
grid, sir, for catalyst, for the nucleus softening.
Come again, come again.
You do a complete grid pattern, the full
You did a
nucleus
quadrant
softening
with
pattern.
Need
grid,
four.
is that right?
Yeah, I do quadrant with grid. In a hard cataract, I don't do a grid, but the grid is only about 1000 microns with a spacing of 400.
So in this case, there was a grid of 1000 microns.
Yeah, 1000 microns.
Right.
I don't like very small pieces because sometimes they stick around, go behind, especially in a torsion. Quadrant पे है ना? जो देना है दे दे यार, कोई फर्क नहीं पड़ता. IP1 IP1 दे दे.
Any tip for beginners, because chopping.
Come
in
again?
a-
Sorry,
any-
I can't hear you.
Any tip for the beginners, because chopping in a pre-fragmented nucleus, it's slightly different than chopping when you're using a normal phaco machine. So when
No, you need very little power and you don't need to actually bury a lot. You just have to get two grips, one on the side, one with the chopper and the other with the tip, visco. That's about it.
What is the size of the rexis you made, Gomipal?
5. If I have a visco de do. If I have a harder cataract, I'll go up to 5.5. A 5 on a visco de do, yaar. A 5 on a femto will always enlarge to about 5.4 or something like that.
sorry for the interruption, sir. The lunch will close at 4 p.m. So any of the delegates who haven't yet had lunch, please move on to the area behind the ballroom. Over to you, sir.
Yeah, that's fine. आइए दे दो. I use a coaxial. ये पकड़ ले यार भाई. और मेरा वो manipulator दे देना. So normally I use a coaxial and I prefer to, when I fill it up with visco. यार, एक मिनट forceps देना. So this was a slightly smaller incision. Bottle थोड़ा बढ़ा दो pressure इसका. Okay, I normally it's better to start with the sub-incisional. Okay. And wherever you have separated the subincisional or the cortex, it's better to just keep continuing along with that because it makes it slightly easier rather than starting from a new place. You can.
Is there any reason you don't use the bimanual technique?
Noshir, when you and I started FACO, there wasn't bimanual.
Yeah.
And I am so used to it. And the point is, this is much faster. And the pore is better. You can see this, it's a round, beautiful rexis. So that's why I'm still continuing on coaxial. The only difficulty in coaxial at times is the sub-incisional
Cortex. Yes.
cortex. But that you can see, you fill it up with visco and start with that. Love visco do, lens do. Ye pakdo. Okay, so I am ready to implant the lens. The lens that I am supposed to implant is the Hoya Impress. That is the advanced monofocal. Yeah, dusra de do.
That is
I'll
the
just-
trouble with methyl cellulose. You get these bubbles again and again.
No, actually खत्म हो गई थी तो उसने ये दे दे. ये क्या विस्कोट है? नहीं कोई मिथाइल सेलुलोज ही दे दो यार. So anyway, this advanced monofocal, the central 2 millimeter is where they have a gradation. It does not require, basically, it does not require anything additional to be talked to the patient. Because the patient really, it's about the same like a monofocal, but the only thing is that the requirement for a plus ad goes down to about 1.75 or 1.5. That's a well inflated bag. इसको load कर दिया तूने? Oh, he's already done my job. That's what I get there. So this goes through 2.2 actually. As I think Noshir, you were saying, this is both up. You can screw it or you can do a push.
Push, yeah.
Yeah, so you can see we going in, and I can use the plunger. Hopefully, मेरे को सिंस की दे दो. ये पकड़ यार, मेरा हाथ खाली कर दिया कर बस.
What is the problem with the hand?
The problem is that I don't like my hand be filled up with something else. See, the point is that why should I have a visco in my left hand or my forceps or something? That's my problem.
So that is what
I need
happens
the
when you can
second-
operate with only one hand. Usually surgeons
Yeah,
are
I
using
can
both
operate
now.
with one hand, but I don't need a useless thing in my hand at that time, right? That's not my problem because my assistants are so well trained, they give it to me the left thing and then they take out whatever is not required. Anyway, that's pretty much the end of the surgery. It's a UV blocker lens. You can see, you can have it in a yellow color or the non-yellow transparent. And then as of now, we don't have the toric in the Impress, which I think should be available sometime next year. And apart from that, it is supposed to be treated and PCO is supposed to be less. Good stability in the Vivinex, which is the toric is there because the haptics are frosted. And that's about it. I think one important thing about this is that the injector is really fantastic. It's really, really very easy to put in and goes through 2.2.
And that is
Yeah,
quite,
we could see that.
yeah, that is one of the great plus points of this, the
Yeah. Any
injector.
questions or anything you want to ask me that I am happy to answer? Or we can shift to the next OT. I hope I was within time, right?
Yes,
Yeah,
yes,
you are.
impressive
Beautiful
surgery
surgery.
with the Vivinex
Very good
Impress.
surgery, Maipal. And
Thank
I'm glad you used the femto cataract modality
Yeah.
also.
But Namrata, I'll bloody kill you. You didn't allow me to show the femto.
Sir, ma'am, है ही नहीं, we'll pass on the
है ही नहीं,
message.
अच्छा, चलो ठीक है. वो कहती है फेमटो नहीं दिखाना. मैंने कहा भाई इतने सेशन हो गए किसी ने फेमटो नहीं दिखाया, कुछ समझ नहीं आया. तो anyway, the advantages of femto, if I may, it reduces the EPT. It gives you a beautiful round rexes. The rexes, as I normally do, is on capsular scanning. That means it's center of the capsule, so the ELP will be good. LRI I do for less than 1 diopter. After that, I do a toric lens. And I don't normally make the incisions because this is a liquid optic interface. A liquid optic interface, normally in a LOI, the problem is that the pressure that is there on the cornea is less. Therefore, there is some movement of small nystagmoid movement, so it's slightly more difficult to enter the incision. So you aren't really getting anything significant out of the incision except for the LRI. Now, that's
Thank you,
about
sir.
that's about end of the surgery. Thank you very much, everybody, for
Thank you for Maypal for an excellent surgery and the femto part.
We can move on to the next
At least we
surgery.
could see the incisions and the free floating capsulotomy.
Can we move on to the next OR? Yes.
Yes, so we have Dr. Anurag Mishra sir with us, who is Director of Radharaman Eye Hospital, Cuttack, and Carvajan Eye Hospital, Bhubaneswar. The patient is 61-year-old male, and we are operating left eye. The vision is 1/60 with pinhole not improving further, and the cataract is NS223 with cortical cataract. In fundus, the patient has early ERM with PVD, and we are planning to implant Vivinic toric of 19 spherical equivalent T9 model.
Are we going to use the Varion technique at all, or you're going to mark the cornea?
Am I audible, sir?
Yes.
Yes.
Are you
audible.
going to use the Varion at all, or no?
Yes, sir. We have already registered the eye. Due to paucity of time, I just skipped those steps. We have already registered the eye with the Varion. We have done the primary and the secondary incisions with the help of the Varion. We have completed the capsulorhexis as well. And we are catching up the action with the hydro. So to answer your question, yes, sir, we have the availability of the Varian image guided system with us, and we will be using it to align the IOL later on.
Okay.
सीधा देखिएगा अंकल जी, सीधा लाइट पे, बहुत अच्छी बात है. नहीं, थोड़ा इधर उधर मत हिलाइए सिर को. The nucleus is slightly on the denser side. There is, of course, the cortical element as well, but the reason why it's not rotating freely is because of the density of the nucleus being slightly on the higher side. But I think, isko mat hilaiye please, mujhe dikh nahi raha. Thank you. Okay, the phaco handpiece please. So we are through with the hydro procedures. We are proceeding towards phaco now. Chopper please. Is this my chopper? Okay, thank you. There is a metallic silverish sheen that you get from the center part of the nucleus. Saline on the cornea, please. As we embed the phaco tip in the nucleus and chop it, rotate, go to the side, initiate the secondary chop.
So what are your fluidics right now?
Yeah, I would love to show you that. If the video camera can please focus on the screen, if the screen can be rotated, and if that could be put on the PIP. Can you see that? Is it visible?
Not really.
Can someone ask the video camera to be focused on the screen, please? Since we don't have the services of an overlay.
Maybe
We'll
you
be
can
happy
just,
to hear you,
somebody
yeah.
can just let us know, because
Yeah, so it's the IOP is set at 20. The flow rate is 23. And
IOP
the-
is set at 20, you said?
yes, sir.
At 20?
20, yes.
Right.
So that's the
For a heart.
reason I wanted the video camera to be focused on the screen. Is the person available?
Yes, now we can see.
Yeah, so 20, 450 and 23 is what I normally use. I mean, that's my staple fluidics parameters for any surgery. There are tweaks, of course, on occasions wherein I'm handling a very hard cataract in the grade 5 pluses or 6, but otherwise it stays stable at 20. I mean, the IOP actually always stays at 20. It doesn't go beyond that. I can tweak the flow rate a bit and the vacuum when I encounter harder cataracts, but not the IOP. That essentially stays at 20.
we could see some surge though in some of them.
Sorry?
I could see surge though. I could not exactly search, but
there
I
is-
could see that the
reason
chamber was
for
not
that
stable.
is- Yeah, there is a slight bit of breathing.
Right.
I completely agree with you, but that's basically because this patient's a little apprehensive. She's squeezing a little, and it's a deep
Oh,
set
okay.
eye.
All right.
It's a deep set eye, so we had to really push the blades of the speculum apart to
Okay.
accommodate the eye and to have a better exposure. That is the reason, but that's nothing that is worrisome. Just a small little flinch at times, not really the surge.
Understood. Yeah.
Nothing
But
that
is
cannot
there
be
any
handled.
particular reason you keep it so low? I mean, we have not had any glaucoma, I mean, in the sense that no disc
So
issues have taken place.
Yeah, I
Glaucoma.
tend to operate in the physiological IOP range, sir. That's just something I like. I mean, I truly believe that it's, if it's something that can be managed in the physiological range, it's always better. That's the only thing. There is no particular reason, but if things can be managed with less fluidics, there's no reason why we should bang it in. So as we can see, this case, yeah, coaxial IA, please.
This is with active fluidics or with even with
This
gravity
is with
fluid?
active sentry, yes. This is with active sentry.
And
but
not
even
with, what would you do with a gravity fluidics?
I have never used gravity fluidics with Centurion, sir. But
No.
if at all gravity fluidics is something I have to use, then I'll keep the bottle height somewhere around 40, 45 centimeters. That will do the job. But I cannot really answer that question, sir, because I have actually never used gravity fluidics with Centurion. But I have used the Centurion without active sentry. And even without the active sentry handpiece came in, I was using the IOP at 20. So even without active sentry, the IOP was always 20. But yes, that additional cushion of comfort came in when active sentry was introduced. So herein also, while I'm doing the IA, where I don't have the services of active sentry because that's only there with the phaco handpiece, you can see that the IOP stays at 22 and the vacuum is somewhere around 600. Even with that, with a normal patient, it would not happen so. It's just because this patient's got a deep set eyes, a little.
Yeah, there's a
flinching,
little bit
but
of
that's-
trampolining also that we could see.
Yeah, just
People
a little
has-
bit.
Yes, but you
Nothing.
managed it very
Just
well.
give me the IOL, please.
So going with the entire day discussion of bimanual versus coaxial, you use the J-shaped coaxial.
Yes,
So
ma'am.
I think
What I-
I think Rajesh is feeling
Hi,
annoyed that he
Dr.
didn't
Anurag.
get it.
Yeah, I am also a very coaxial person, and because we have been using it for years. So yes, I do use the bimanual, and that's what I use today. I do use it, but very less often. Very less often, occasionally.
So I
when
use
it
both
is-
equally, whichever comes in the tray. So I
Okay.
think it's just a matter of getting used to.
Very
Both
good.
have the,
With
we can be
coaxial-
equally fast.
Yeah, with
With both
coaxial, we
hand.
feel that we can
Irrigation
even play
cannula,
hockey
sir.
on the posterior capsules, but with bimanual, it's not the same kind of
Of course, you
feeling
don't play
that we
hockey,
get.
yeah.
It's
No,
just-
no hockey on the PC. Yeah. Agreed.
That's what I was telling, that it's just a matter of getting used to a particular thing. Like those who are used to bimanual, they can do whatever. It's like that.
So I don't know if Hamni in the audience saw, but what Anurag did for the last piece was really, I almost thought that the transmission was not good. You actually got the last piece out in slow motion. I think it came to you at, at spinal level, but that's a perfect demonstration of how to take out the last piece.
Okay. And which lens you are implanting, Dr. Anurag?
I'm implanting a Vivanex toric monofocal IOL, sir. We're just coming to that, and it's a very heavy toric. It's a 19.5 T9.
With the multi-cert injector, right?
With the multi-cert injector.
Yeah.
Excellent implantation.
Yeah, gives a
comfort
lot of
they give.
happiness. Gives a lot of happiness when you are injecting with the multi-cert injector.
Best injector in the world is what Mohan Rajan sir is saying,
it is
standing beside
very
me, and
smooth
he is
and,
actually right. It's the best injection system in the world.
Yeah.
And the material quality, I mean, that's something we often don't talk about. We stop, when we talk about the Vivanex, we stop at the injection system. Seedha dikhega, uncle, please. Seedha dikhega. Don't switch on variant now. I'll tell you when to switch it on. So what we don't really speak about is the material quality. And the material quality, we have objectively assess the material quality of different IOLs with the eye trace. We are doing a study on it, and what we have found out is the Vivinex is right at the top. It's the best material, one amongst two. Please switch on Varian now. We should be close. Please switch on Varian. Yeah, we are close. We just need to rotate a little bit towards the right-hand side, and we are almost done. So if the pupil comes down, we just have to retract it a little bit with the second instrument so that we see where the marks are. The marks are doing fine. That's where we withdraw the irrigation cannula and put it where it was. So the frosted haptics of this platform actually gives it excellent rotational stability post-operatively. And even if it's a high or a low toric, you shouldn't flinch about putting it in because the rotational stability is excellent, the material quality is superb, implantation is magnificent. So every component actually is there to make the surgeon happy and take decisions to implant it more frequently in the patients.
Yeah, actually, this textured haptic now is being used by a couple of other companies also, but it was started first with Vivinex.
So
Okay, thank you. I think we'll move.
next surgeon is ready. Next surgeon ready. Next case.
So can we move to the next case?
Can we move it to this OT?
Anurag, excellent case. I think deserves. Nobody is applauding here. That case definitely deserves an applause.
Thank you so much, ma'am.
So Gaurav, you are doing the next case?
Yeah, I'm doing your case, Dr. Namrata.
Okay.
So we have Dr. Gaurav Luthra sir, Director of Drishti Eye Hospital, Dehradun.
No need to introduce, please tell about the patient. Yeah.
The patient is 54 years old female with vision 2/60, not improving further. The cataract is thick PSC. The cornea is poor with ghost vessels and corneal opacity. The endothelial cell count is poor, 1364, and there are guttae. So sir is going to implant Vivinex toric multi-cert. The power is 21.5 spherical equivalent T4. Over to Dr. Gaurav Luthra, sir.
Thank you, thank you. Can you hear me?
So Gaurav, you've done the Rexes already?
So I've done the Rexes. There's a generalized corneal opacity, and I used dye, and it was a bit challenging, but I've already done that. So as per the requirements of the day, I've decided to save time by keeping this ready. So there goes the capsular remnant. I'm using a Centurion today. And you can probably appreciate the corneal opacity right in the middle. It's a diffuse, like post-viral keratitis kind of an opacity. It's a sticky kind of a cataract to some extent.
Yeah,
So I
it's a
think
bit
when you have
sticky.
that corneal haze, you have to modify your incision a little bit, which Gaurav has already done, because your maneuvers should be from the area which is relatively clear and not from the area where haze is there. Again, you have to remember to put your retro illumination on because this is a dense cataract, and if you don't put your retro illumination on, then later on there may be a problem because you'll not be able to
Can we
gauge.
have the, Gaurav, can you have the overlay of this? You can't do that.
So actually we are on the RTO
They
where
must
the
be on
overlay
the
doesn't come.
RTO is
Acha.
difficult to get the overlay.
Okay.
But RTO is a great,
I'm
great
using
machine to do
IOP.
corneal opacity with
Yes,
cataract.
yes, absolutely. So I'm using an IOP, and what is the IOP settings, Batana, please? So IOP is 40 here. And it's a bit of a sticky cataract, so trying to do lateral separation. Quadrant removal.
So, and it is always best to remove one quadrant, because when your one quadrant gets removed, your glow is seen, so your visualization gets better because it's not getting camouflaged into gray and white. Rather than, making 6 spokes and then eating away the nuclear fragments, it is best that you get one quadrant or one pie-shaped piece and then eat it up, and then automatically, so beautifully Gaurav is demonstrating, everything is coming out.
Gaurav, you're making it look so beautifully easy and seamless.
Thank you, ma'am. Thank you so much. So I have a big responsibility. The patient here is my OT senior most nurse, and she wanted to get operated by Dr. Namrata, and she said, I want to get operated by cornea surgeon. She's been waiting for the last year or two, thinking that, you know, the day somebody really fancy comes along.
So you've done a great job, Gaurav.
Thank you.
Yeah, fantastic job.
Yeah.
Now we can see that corneal opacity very clearly and underneath that, over that, red glow.
So I think this is vital. The glow makes a lot of difference. And you'll see that as you implant the lens, everything would look a lot more clear. And you would wonder why, everything was so hazy when you were
Are you on pure retro illumination or
No.
not?
No, not pure.
I think it helps a lot if you go on retro illumination.
Yes, sir. So I'm now doing a bit of a posterior capsule polish. I have sandblasted. These are customized irrigation handpieces that I make for myself. I mean, I get them made for myself. And I've done all that hydro to loosen the new cortex as well. I showed in the morning how the cortex becomes so nice and loose that you don't need to do much, you just aspirate it. And now with the infusion running continuously, I'm aspirating. So there's a fluid flow being set up here. I don't know if you can see it.
Yes.
So now there's some bit of, I'll just flip hands because there is a lot of PC plaques there. And then we'll implant. Lens ready, Karlo? Okay. So what I like to do is I just go in from here and then I'll just do a bit of this polishing from the main port with the infusion on. So what sister light mein dekhte rahiye. So I'm just polishing and you can see that the plaques are all going away. So my infusion is on. I'm going from the main port because it sets up a good flow of fluid and everything is now getting polished away. So much of it is gone. There's very little plaque left. So I'll just remove that one small bit of cortex which is remaining there. And I think now we are ready to implant the lens. So both my handpieces are sandblasted. So I can't obviously remove everything. There's still some that remains, but probably that will not trouble her much.
So I think multi-cert.
I love the injector. I think it's one of the best
It is a
injectors.
really nice injector, and you don't have to. You don't even have to remember how to use it because the steps are written on it. So 1, 2, 3 is already written on it.
And the best part is you don't need to do wound-assisted injection. This injector from a 2.2 goes in very easily, delivers straight in the bag, and the aisle handling is just so amazing. So for torics also, I find that this is one of the best lenses to use.
Yeah, because the external diameter is just 1.62, I believe.
1.6.
Yeah, 1.62. And you have a 2.2 millimeter incision, so it does not distort the wound at all.
So now, this is exactly what I was saying. Once you put the IOL, it looks so clear that, haze gets, looks
So
as though the haze is
of
much less. But
because of hydroimplantation, I don't need to do any kind of visco removal, but I'll use this cannula. This is the Herschel Tuck cannula which I use for sealing my main ports. I started using it a few years back and there's no going back. It's beautiful. It's a blunt cannula, it doesn't cause DMDs, and you can hydrate the side ports very nicely. It's not a very long cannula, so the control is excellent. And of course, I should have a financial interest if Herschel allows it, but I don't think he has any either. So anyway, so I'm done. I think now we want to move. Dr. Mansi had requested that we move to Vivekanand for one case because they have one case ready. And I'm really grateful to Dr. Mansi also for agreeing, on short notice to actually allow surgeries at her place, and she's been a great help. So I'm passing on. Please, we can move the transmission there as well. I think, wait, sorry.
Didn't use
so we have,
Varion.
we do have.
So we received a call from Vivekanand Netralaya that they are not ready yet. So then Dr. Mohan Rajan is ready in the other OT. Can we switch to that?
That was a beautiful
But we all
surgery.
must thank you and congratulate you, Gaurav, for an excellent facility that is there at Drishti.
So we don't have the panelists from the next.
So for Upper Swami, we need panelists.
No, it's okay. We are anyway here. So Dr. Mohan's OT, please. Mohan's microscope. Can we shift to the next table?
So I think, Dr. Namrata, can you check with Vivekanand people because they had said they want the OT after this. But because Dr. Mohan Rajan's Upper Swami machine was being set up, I tried to finish off fast so that I think Mohan Rajan sir is also not ready for take 2. Can you please check with Vivekanand first and see if they want to start off there? because we'll be ready in 2-3 minutes after this. Huh?
Gaurav, you will have to contact Mansi, please.
I'll do it. I'll do it.
So I think that was a great demonstration. Some of the cases which are not run-of-the-mill, like the last case, was an excellent case to demonstrate in a live surgery, because those are the kind of cases where I think the audience who's sitting here would need guidance. Otherwise, the routine cases, everybody I think is well versed. So, any other tip, Rajesh, would you want to give for corneal opacity with cataract?
Actually, if there's a haze, then what we have found out that you will also agree, you have also done it. In a haze, if we use a chandelier illumination, you can very nicely see the rexus margin when you're doing it.
Chandelier helps a lot tremendously.
Yeah.
If you can use the chandelier, especially in very dense opacity also.
Absolutely.
The chandelier is a great boon.
Yeah. And plus, if there's an opacity or haze, if you cannot use chandelier, you can use these
Endo-illuminators is also a good trick.
When you are actually chopping the nucleus, some assistant can help you by showing the illumination from outside. And when you have to take the epinuclear plate, you can take the endo-illuminator inside to the side port, so that you can exactly catch the epinuclear plate and not damage the rexus. So in these cases, as Gaurav had also stained the capsule, in these cases we should keep the trap and blue stain for a longer period, because it will help not only to do rexus, but also will help to protect the rexus margin while you are chopping. Otherwise, you can accidentally chop the rexus margin. So you can exactly see the margin of the rexus, and then you can save that while doing the nuclear chopping.
So, Somshila, you've implanted these lenses, the Hoya lenses. What is your take on it?
I agree with the surgeons that it's excellent material and the insertion is extremely smooth and it goes in with the multi-cert very, very easily.
I think actually one of the first to use these lenses in 1995, and I've used a couple of thousand of them. The material is excellent. There's no opacification of the material itself. There's very little PCO, and the best part is that now the multi-cert, with the multi-cert you can implant both ways. You can screw with the screw technique as well as the push technique.
So I think Dr. Manpreet, you've done a study on these Hoya lenses. Can you tell us about that?
So we have all been raving on the injector system, which of course is par excellence, but the material is very, very good, and in fact the PC compatibility because of the UV ozone treatment, and what we found in a study that has recently been published in American Journal of Ophthalmology is that the PC adhesion is excellent, and in fact long-term PCO in the center, which requires yak cap over a period of 3 years, was one case in a series of over 100 cases. So that's really excellent, the material. The biocompatibility with the posterior capsule, it adheres to the PC very well and prevents proliferation and migration of lens epithelial cells. So that's excellent.
So there's a question from audience.
Ma'am, in last few cases with Hoya 150, with the preloaded injector, what problem I'm having that it flips, and secondly there are cuts on the haptic. So though it's preloaded, it's not in my hand. So what I'm doing wrong? Can you suggest something? For last 4 cases I'm having.
Can you just repeat
what does it do? It slips?
Flips.
No, it
Preloaded in Hoya 150 monofocal, the basic Hoya preloaded, and there are cuts on the haptics.
No, that is in the preloaded one. It is unlikely because
you
are
talking
not
about
loading
the Hoya preloaded lens?
Hoya preloaded, very basic one. Hoya 150, the base.
You mean the Vivinex?
No, ma'am, very basic one. What?
But
the Nanex one or the which one?
I think the preloaded one. We've implanted so many lenses.
Sorry, because now only we got this data.
We have not found any. We've done thousands and thousands of lenses.
Earlier it was okay. For last 3-4, it's happening almost in all cases. If something
so I think
do you inject the viscoelastic through the
yes, sir.
hole?
Yes, sir.
Okay, because it can, if it's dry, then it may rub the surface.
No, sir, I make it sure that it happens. It's for only few cases it's happening. I don't know what is gone wrong. It's almost cut that haptic will break out. So
No, 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 I
No,
think
no, I don't know.
So
there must be
if
some
the-
problem
Actually,
in
I'm
handling.
talking about 150 is not the Vivinex or the Nenex.
No, no,
These are the
the
late. This is much earlier.
Yeah, the very basic
But
one.
there also, if you really implant it properly and follow the steps 1, 2, and 3, then there's very little chance that you will get this problem because
IB 65.
breaking of the haptic at the optic haptic junction as well as flipping is something which is
Sundara?
doesn't normally happen with a Hoya lens. So I don't know why. We
So,
can ask the manufacturer.
Yeah, it could
if
either be
the
just
company is it's a particular batch or something like that, but otherwise it doesn't happen.
There's only one time when you have these lenses having problems, that is if they are stored at very cold temperature, colder than recommended. Like you can, it's usually up to 16 degrees, but if for some reason your storage facility is cooler than that,
Table up,
and
can
you
you
don't
put?
get the lens a little thawed, and then you can have this, it stays very brittle.
Yeah,
Then you
it
can have this
is,
problem.
yeah, we've not had
Otherwise, I
such a
can't
problem.
think of any